Okay. Good morning. You roll the slide for me. So, before you can talk about kidney disease or kidney failure, you have to talk about kidney function. And we consider GFR as the marker of kidney function, so glomerular filtration rate. And there's a simple sort of hemodynamic calculation of what is GFR. So if you take the cardiac output, which we'll call 5,000 cc's a minute, the heart rate is 70, the stroke volume is 70, that's 5,000. So the 20% of the total cardiac output goes to those two small retroperitoneal organs, the kidneys, right? So 20% of 5,000 is 1 liter, 1,000 cc's a minute of blood flow to the kidneys. And of that 1,000 cc's, 60% of that is plasma. If your hematocrit's 40%, your plasma is 60%. So that means the plasma flow is 600 RPF, is 600 ml a minute. That's what the kidney gets. And of that, 20%, the human filtration fraction, is 0.2. So 0.2 of the 600 GFR is the filtration. That gets you a GFR of 120 ml per minute. That's in a man. A woman would be closer to 110. Okay, but if you take that number and calculate it by minutes in a day, that gives you 172 liters. That's 45 gallons. That's more than your garbage. Okay, that's the daily GFR. Now think about it. So what in your daily urine output is somewhere around 1.72 liters. I've listed there at the bottom. So that FE is fractional excretion of water. So if you filter 172 liters and you put out 1.72 liters, that means 1% of the filtrate became urine, right? And that's about the number. So the kidney filters 172 liters of plasma daily, produces 1% of that as urine. And what does that get you? Well, what that gets you is if a 75 kilo man is 60% water, 45 liters, 4 times 45 is 180. So that 172 liters a day would filter total body water 4 times. So that's what it gets you. That's a 4x filter. So the bottom line on that page is, what is GFR? It's a 4x filter. That's the mathematics and that's the hemodynamics of what is GFR. But it's a reminder of what the kidney does. And the amazing thing is, so to get to that 172 to reduce back down to 1.72 liters of urine, what does that mean? That means the kidney has reclaimed 170.28 liters. So think about it. So you have this massive blood flow to the kidney, this remarkable filtration, and of that 170 plus liters of filtration, 170 liters is reclaimed. So it's kind of like this hemodynamic filtration system, and then this oozing sponge that just oozes the fluid through the tubule and back out again, right? So if you measure urine creatinine, the average urine creatinine is about 100 times the serum creatinine. Why? Because you filtered 100x of it, and you left all 100x in the urine, but you took out 99% of the water. So what did that do? Well, that just concentrated the creatinine 100-fold. Pretty simple, right? It's like you desiccated the urine if you just pulled the urine. So to me, that's GFR. Okay, and we use a lot of these GFR calculations, and it's important because now the labs are so good at estimating GFR, and it even comes without even asking for it, right? All the lab tests give you an estimated GFR now, and they're pretty accurate. That even those equations that are used are gotten better over time. So those estimated GFRs are pretty darn good. Any questions on that one? Has that one ever been explained to you before? But that, to me, that what is GFR? There are a lot of kidney functions, but when you talk about kidney function as GFR, that's it. And it's pure hemodynamics in its genesis. If you think about the volumes, it's staggering. Yeah. That's a 55-gallon drum is that big steel drum they load off of trucks. And 30 gallons your garbage can, the one you just grab like that. So that's your daily GFR. It's halfway between a garbage can and a steel drum. That didn't come out very well. I was afraid of that.
We printed it out for everybody.
Well, the case study.
Oh, the case study, I'm sorry. We'll send the slides to everybody too.
Okay, so what is CKD? Well, we tried to sort of come up with very basic descriptions of what that is, and I think the best is that those two on top. So any urine albumin greater than 30 milligrams a day, and any GFR reduction of less than 60 ml. Okay, so that, now sure, there are structural, you can add in ultrasound definitions, including renal scars, infarcts, polycystic disease, renal vascular disease, obstructive disease. So obviously, you can see structural kidney disease with ultrasound that wouldn't necessarily require you having a depressed GFR or proteinuria, right? So in early autosomal dominant polycystic kidney disease, which is the most common hereditary disease out there are a lot of these patients running around with big cystic kidneys and their GFRs are normal, right? Their urinalysis is normal. So do they have CKD? Sure. They have a chronic kidney disease. It's just not advanced to a point of proteinuria and a GFR less than 60, right? So I used this just to kind of be the simplest of definitions. So what does it mean? Well, there's a lot of meanings, and I'm going to bounce back and forth. So the biggest meaning is that progression to renal failure, which is kind of my arena, is really what it's all about. What's the percent of people in this CKD population that are prone to development of progressive renal failure, and what are the other accompanying defects in disease management, disease development. So it turns out your risk of renal failure, ESRD, is end-stage renal disease. So if you have just isolated 1+ proteinuria on a dipstick, your lifetime 25-year Mr. Fit data risk is 3%. If you have 2+ proteinuria, okay, that would be more than 500 milligrams per day. If you have a 15% 25-year risk of developing total kidney failure on dialysis. If you develop early CKD, where your GFR actually is now depressed, that alone, and that implies normal urinalysis, so that would be a lot of sort of our hypertensive population, okay, that now do have enough nephrosclerosis that they do have depressed GFR. They have a 2.4% lifetime risk, lifetime being 25 years. But if you have 2+ proteinuria and a depressed GFR, which is my clinic, basically, then you have a 41% chance of ESRD development. Okay, so those are progressor. Those are the people who are tagged. They have it. It's tagged. You're it. You have renal disease, and you're going to have renal failure. So this is kind of a general topic. So let's just see what I put next. Okay, I think there's more power to this study than you can even gather looking at these three graphs. So this is 1 million San Franciscans in the Kaiser Permanente group. So these people had insurance. Okay, this wouldn't be all of society, I'm afraid, but it's close. It's 1 million people carrying in Kaiser insurance, okay? And they were followed for 3 years. Now, this is the breakdown. You guys see it? I'm a little trouble with that. So estimated GFR, and the top one is death. So take a good look at that. So in 3 short years, if you're in the Kaiser group, and your GFR is between above 60, that's half of they call that now 3A, is the first 15 ml loss, second 15, third 15 is stage 4, and stage 5, and those weren't all on dialysis. I think they were mostly. But kind of exclude the last group, because I can't tell you for sure how many of those were on dialysis, how many weren't. But you can see the graded risk for death, cardiovascular events, and hospitalization from just simply a GFR decline. And it goes from 1 to 11 in death. So your death rate is 10-fold from a creatinine. That's early 45 to 50 would be a creatinine of 1.5. Okay, and at any 15 to 29 would be any creatinine over 3. Okay, so you get a 10x death rate, hospitalization rate, and cardiovascular risk rate from a creatinine that goes from normal. You can see even the early change is minimal. So the early CKD doesn't carry the cardiovascular morbidity, but those people don't die from lack of dialysis. Okay, that's not what the death rates were all due to, or some complication of it, because the first 4 bars aren't on dialysis, and a number of those far on the right are. Okay. in your clinic and what you guys do every day, you see creatinines in the 1s and 2s all the time, I'm sure. And you just have to, it just has to be a red. It has to be one of those bars in red. These are the patients who carry the morbidity. They're going to have more cardiovascular events than they're going to have more death than the rest of your patients. Same applies to albuminuria. So these are, it's not quite as striking, but if you, certainly microalbuminuria, that's dipstick 1+ generally, is a cardiovascular risk factor. It predicts about 1.5 times the death rate in cardiovascular events, 2 times for cardiovascular events. But 2 to 3+, macroalbuminuria greater than 300 milligrams, it carries a 2 to 3x fold. So you can break it down similarly by just degrees of albumin. These are tertiles, so this is normal, trivial, minimal. Then microalbuminuria is in the middle, and that's dipstick 2+ proteinuria out on the far right. And it's just a curve. It's just a graded curve for cardiovascular events, death, and heart failure hospitalizations. Same story, same kind of risk parameter. Probably not identical to the creatinine measurement, but it's overlapping and it's predictive. And it's who you see. Now, you guys probably don't order a lot of your analyses in your clinic because your docs don't want to see that, right? Because then you have to deal with it. For what do we have in here?
Oh, I think they get it.
Okay, so this is the biggest point of this talk, I think, is that CKD is a cardiovascular risk factor. And obviously the diseases overlap, right? How much diabetes, how much hypertension, how much atherosclerotic vascular disease burden is in it. Well, it's all. I'm sure there's going to be some standalones.
Is it the chicken or the egg?
So the problem is we don't see them as the early process here. Let's kind of go back.
Oh, yeah.
Go back to that original fuzzy page.
This one?
No, keep going. Keep going. That one. I have it here somewhere. Okay, so just since I wasn't sure exactly what you guys wanted to focus on, I've thrown in a few kind of CKD pointers here. So what are the evolutions of, as you advance through renal failure, what comes about? Okay, so edema, you've all seen that. You see this pulmonary edema, you see this peripheral edema. And hypertension should be listed in there. I'll make a point that CKD begets hypertension, even if hypertension wasn't the preceding chicken or egg, right? Mm-hmm. So you don't, once you develop kidney disease, there's an associated hypertension of kidneys. It used to be called renoprival hypertension. That was shrinking kidney or declining kidney, hypertension of the declining kidney. And if you look through those grades, like 3A, B, 4, and 5, the incidence of hypertension is rising. It's almost 100%, 80+% as you get to stage 4 and 5 in renal disease, even if you didn't have hypertension before your renal disease. So there's something about the disease itself, and it's called in the old days renoprival hypertension. But I think the simplest mechanism is volume, is total body sodium. Even though many of the early CKD patients aren't visibly edematous, they have subtle volume retention, sodium retention. And that gets to the point of then how do you treat a lot of these people? I treat most of them with diuretics, even if they're not coming in short of breath and edematous. If they're hypertensive and they have established kidney disease, I think diuretics are first-line drugs. Second-line drugs are ACE inhibitors and ARBs. I think it's been pretty much proven in every subset of renal disease, except maybe the ones who have absolutely no proteinuria, that lowering blood pressure to 140/90 and probably 130/80 and any degree of proteinuria are indications for ACE inhibitors. The different societies argue now, and it's changed even recently, on what is, especially in the diabetic population, what is the target blood pressure in a diabetic in this country. And some of the societies and the cardiac and the hypertension societies have gone to 130/80. The diabetic society is still hanging on to the 140/90. And that Accord trial that was published in recent years has put a lot of, that was the 140 versus 120. And there was, other than stroke, there was a slight mortality disadvantage to having your blood pressure lowered if you're diabetic to 120. So there's always confusion in there, but always a diuretic, always an ACE inhibitor if they can tolerate it, and target if they have proteinuria, I take their blood pressures to 130/80. That's probably the biggest recommendation from this talk I can give you. But I think the diuretics get sort of left out of the picture sometimes early on, because there's so many calcium blockers and ACE inhibitors out there that but I think you have to think of mechanistically, hypertension and renal failure typically has a volume component, even though you can't see it detected clinically. So hyperkalemia generally late in renal failure now with all the ACE inhibitors and spironolactone use, obviously CKD patients, even with mild to moderate renal failure, develop hyperkalemia on drugs that inhibit potassium secretion. All those drugs inhibit distal potassium secretion. And that's why they're problematic. In my clinic, everybody's on a low, if they're at any risk for hyperkalemia, they're on a potassium diet. And in central Illinois, July and August is the potassium season. And you have to put them all on low potassium diets, especially in the summer, because of the melon and the tomatoes and the potatoes and the beets and everything that grows here. Okay, and they're not giving it up. Okay, I have plenty of experience that tells me they go to the picnic on Sunday, they don't miss out. Okay, my favorite story is the wife of the little guy who went to the picnic on Sunday, and it's Monday morning. This is back when the dialysis unit was on the first floor of my office. And I drive in at 8 o'clock in the morning. She's over there waving at me from the parking lot, and he literally can't get out of the car. She got into the car, but he can't get out of the car. And his potassium's 8 or whatever, and he's paralyzed. Unfortunately, it paralyzed his leg before it paralyzed his cardiac conduction. But he was alive, and he was in the car, he just couldn't stand up.
Oh my goodness.
And he'd been to the picnic.
Wow.
And he ate the melon. And it was Monday morning, and it's always 3 days from Friday to Monday, so it's always the long period. So sure enough, he had hyperkalemia paralysis. So metabolic acidosis, what is that? Well, the kidney excretes a modest amount of acid every day. We generate somewhere between 60 and 80 milliequivalents of acid a day. It's a modest amount compared to carbon dioxide, which is like 15,000 milliequivalents a day. So, and that's why you quit breathing in 20 minutes, you're dead, but your kidneys quit for 2 days and you're not dead. And so the acidosis in kidney failure is relatively modest. It's cumulative. Over 7 days, you have a severe metabolic acidosis. You have no kidney. When dialysis patients, if they didn't dialyze, they'd have metabolic acidosis. But it's modest. And it's failed acidification, failure to neutralize that daily acid load, which ends up in your urine every day. Bone disease and hyperparathyroidism, that's a whole talk. Anemia, I've kind of left that alone. There's been a shift in this country in 10 years about the treatment of anemia and CKD, and the bottom line is you can't measure a benefit other than symptom, quality of life scoring. So there is no cardiovascular benefit, and in fact, in dialysis patients, if you push their hemoglobin to 13, they have a higher mortality. And a lot of those early EPO trials in the non-dialysis patients, and it wasn't until 2009 that they put a black box warning on those drugs. Okay, so now you cannot say you have to warn patients that these drugs have thrombotic events, doubling of stroke. So the final trial, the TREAT trial, I think it was in 2009, diabetics with CKD, they randomized them finally to blood and EPO at hemoglobin under 9, and they just transfused the ones up. They doubled the stroke rate in the EPO patient. It was low grade, but over the length of the trial, I think it was 1% per year. So you have to tell your patients if you're going to treat their anemia, you guys probably won't get into this with your attendings. They're not going to want to give EPO to these patients. And then there was a big heart failure trial, a couple of years ago, same drug, Aranesp, and it had no benefit in heart failure. Now, they had hemoglobin to 11, so but our patients, So what do? I treat them below 9. I let them ride, and it's amazing how long they can go in advanced coronary artery failure. They don't need any EPO. And what I do is I always check their irons. There's even an iron heart failure trial now. But I think iron works in CKD, and there's certainly no reason to put them on an expensive drug, EPO, if you can raise their hemoglobin a little on low iron. And uremia, which is, dialysis, what pushes people into dialysis. We see very little pericarditis anymore. I saw a lot of it when I think we dialyze people better than we used to. And people start dialysis without, advanced uremia. You talk to your boss, and they do open heart surgery on dialysis patients, and he always says, man, it took me all forever to get the pericardium off. So they may not have clinical symptomatic pericarditis, they all have pericarditis. I mean, it's there.
The furry carpet of the pericardium. Describe it literally.
I mean, all he wants to do is get to the coronaries, right? He can't get the stinking pericardium off. Okay, so what is evaluation? So that now we have these great equations, okay, and they're all built into our computer system, our lab system, and you don't have to know which one's which, but they've evolved and they've gotten better. The Cockroach Gulf was around forever, and now these MDRD and these CKD, and now that if you have cystatin C is that bottom one, so that's probably coming. They haven't been able to standardize that in a lot of the labs, but basically I think our lab is the CKD epi formula, and it's very good. It comes very close. What's recognized is that the near normal GFRs, the creatinines that are close to 1, there's more splay in there. You don't get quite the accuracy of the prediction. So the bottom line is these are just lines. They're just taking 100 people's creatinines and sticking them all on a line. Well, they didn't all end up on the line. There were, some there, and they bounced all over the line. So you don't know where your patient is to the line. And all the report is given you is the line, right? So those are regression equations, and they've taken populations of patients and they've made up those formulas, and they're good, very good. But I'm just telling you, a creatinine of 1:1, it's hard to know where people are, and a lot of times they'll land in a CKD definition. Their GFR will be 59, so they fall into my definition. I don't know if their GFR is 59. They could be 69, they could be 49. Because that line wasn't so accurate. It's good for the renal failure patients, but at 0.9, you'll see these little old ladies, sometimes they'll come in and then they'll say they have CKD, and it's short of a timed clearance study, you can't measure GFR any better than this. So my method, Smith method, is I just take creatinine, 100 divided by the creatinine times 0.7. And that's MDRD. That's my version of that middle equation. So if you, for some reason, they don't get the GFR, some of these outlying labs, I go to Carlinville and some of these places, and sometimes the lab isn't on there where they put a conversion on there for you. So if you want to just shoot from the hip and get a GFR, 100 divided by the creatinine times 0.7. And that typically works better as the creatinines go up. So as the GFR is going down, those equations become very good. Just for interest, they took everybody in that trial. The MDRD trial was a modification of diet and renal disease trial. And it was a renal progression trial. And it was a diet, most interested in diet. But they took everybody the day their creatinine hit 4, and the average creatinine at 4 was 14. So, bottom line, that's stage 5. That's pretty much approaching at stage renal disease. But at a creatinine of 4, your kidney function is 85% gone. So at a creatinine 2, it's about 60% gone. So you don't realize that you're 2/3 of the way to dialysis when your creatinine hits 2. Okay. So I have these stages, and albuminuria, that's a KDOQI. This is a guidelines group that comes up, but they've defined albuminuria as 1A, 2A, 3A. It's basically normal micro and macro albuminuria.
So when my patients come in and say, my kidney specialist told me that my kidneys are functioning at 10%, what's that? calculation that
It's going to be a creatinine 6. So 100 divided by 6 would be 16, and 0.7 of that is 10.
you're, okay,
So-
so going, the GFR is the percentage.
Yeah.
Okay.
Yeah, well, if you say 100 is 100, so probably in a young muscular man, a GFR of 120, right? But if you just throw everybody together and say their GFR is 100, starting out at some point in our early age, right? So we're all somewhere around 100, and I just use that as the percent. So maybe if you start out at 120, the percent isn't quite, but I say the percent is the GFR. So if you're at 10%, your GFR is 10. At 10%, they're getting sick. That's when they're needing to know that they're heading into dialysis. So this MDRD trial was a big study. It was a whole timeline study of modification. It was dietary protein restriction, which we kind of backed off of. It didn't have much of an effect. But they looked at risk factors, so it went with degree of proteinuria, level of hypertension, African American race, and somehow at low HDL teased out of there. But those three wouldn't surprise anybody, right? The first three. The more proteinuric you are, the more hypertensive you are, and the more African American you are, the more renal failure. Right? 3 to 4 times. CKD is more than twice, and end-stage renal disease is 4 times, 3 to 4 times the prevalence of advanced renal failure in the African American population. So I list a couple of the common causes of CKD. So in my clinic, it would be the top 2. We still see chronic nephritis and vasculitis, and ADPKD is around here a lot. There seems to be a fair amount of genetic presence of ADPKD. It's a funny disease. It can be very indolent, and people. There's a subset of patients that never reach end-stage renal disease. I mean, that's in families, and it's always interesting that the first person that shows up in the renal clinic, with the creatinine 2 and big kidneys, and they say, "Well, is anybody in your family on dialysis?" And they say no, and then they go to their reunion or Christmas, and they start asking around, and then there's people that have it, and so it's just none of them have reached dialysis or transplantation.
We've seen several patients, Dr. Smith, who have presented with aortic dissection because of their uncontrolled hypertension and polycystic kidney disease, and it's just been found incidentally on their scan for their dissection.
There was a young guy in our clinic. That's probably
It's our patient.
Yep.
I think.
I mean, his dad
His dad had it. Yep.
Yep. So I mean, that's scary that's his presentation. So then you add in all that, secondary manifestation of valvular heart disease, aortic dissection, aneurysm, diverticulosis. So it's some polycystin. That gene's identified, polycystin, and it's some sort of adhesion kind of molecule that allows cells to hold together, because that's what the cysts are. The renal tubule becomes cystic, so that they don't hold together in some way, and they form a cyst, and they're just urine cysts. That's what the disease is. Okay, so what do? So what's my evaluation? Is urinalysis and a renal ultrasound. So it's basically an H and a P, and a look and listen, and an ultrasound, and an imaging study, and then you have to make a call. And so it's not a real sort of elaborate, flow diagram of how do you diagnose CKD. So I just threw this in there to remind you that because you guys use a lot of these spironolactone and ACE inhibitor ARB combinations now in these heart failure patients. And there are a lot of drugs out there, and there's a couple hidden ones. So the top 4 about, and the potassium-sparing diuretics, but amiloride and triamterene, which are they used to use these combinations, Maxide and Diazide. Those were combinations of HCTZ. They're still around. You don't see them as much. And occasionally those drugs are used primarily. So amiloride, I use amiloride occasionally. So, but the hidden one is the Bactrim and the Septra. So those drugs are given commonly over the phone by the primary MDs for the recurrent UTI or skin abscess, and those drugs it's the trimethoprim of Bactrim that acts like triamterene. So the triamterines and the trimethoprim, so they block the distal sodium uptake, which impairs potassium secretion. So they are potassium secretory inhibitors, and they appear overnight. Same with the NSAIDs. Okay, then you can go to Walgreens and buy half a dozen different types of NSAIDs now, right? So patients take those drugs on Friday night for their gout, and by Saturday or Sunday or Monday morning they're in the clinic with hyperkalemia and edema. So that's common. In the hospital, heparin is a occasional cause of hyperkalemia. Those cyclosporin and that's Prograf, those are common transplant drugs. They cause it rarely, but beta blockers inhibit renin. So they work at the top of the chain. So anywhere down the chain, from renin to angiotensin to A2 to ARBs to spironolactone, which blocks aldo at the receptor in the distal nephron. So anything that blocks along that route is potentially a cause of hyperkalemia, and that's all literally some form of aldo interruption at the end, which is the final secretory effect on potassium. Almost all the filtered potassium is reabsorbed. So the kidney regulates potassium, urinary potassium excretion, through distal secretion, so it puts it back. And that's why these drugs are such potent inhibitors or causes of altered potassium homeostasis, because that is the ultimate step, the final regulatory step of what is urinary potassium. Okay. Any questions? Is this all new, or is this just hitting on old points again? I don't know how much you guys get in your training days. Do you get a lot of this in the physiology stuff? Pathophysiology?
So, yeah.
Yeah, I think it's a good reinforcement.
You saw that one. Okay. So what's on the forefront here? Well, these are SGLT2 inhibitors. Have you prescribed any of these?
No, but I'm recommending them.
So these are game changers, I think. I think they're going to be more and more. So these are diabetic drugs. They started out there. So SGLT2 is a transport protein in the kidney that co-reabsorbs sodium and glucose, proximal to. So now these drugs have become anti-diabetic drugs. So they cause glycosuria. They cause glucose spill in the urine. And 25 years ago, as a resident or a fellow, and I mean, that seems so antithetical to think that we would encourage the diabetic to glycosuria, okay? Because that was that in the early days, that was the marker of diabetic control, right? So when you have to exceed 180 or 200 milligram per DL glucose to get it into the urine. That exceeds the kidney's reclamation capacity. So when you double a normal glucose, that's when it'll appear in the urine. It will spill through. That exceeds the renal reclamation capacity. And that's what these drugs are going to do. They're just going to block out sodium glucose reabsorption, mostly in the proximal kidney, so that you then get a distal sweep, essentially, of sodium. And over time, the distal nephron compensates. It's just kind of like diuretics. It will then make up and it will conserve sodium as you spill more sodium distally. Okay, so over time, the glycosuria persists, but the net diuresis, natriuresis, the diuretic effect of the drugs wanes. Early on, the GFR drops, but it stabilizes, and now there's longer term. There's a renal. This drug is pagliflozin. Is hard to say, but there are now trials that look at outcomes, and I'll just slide for that. But it now seems to even impact decline of kidney function in diabetes.
This was a hot topic at ACC.
But this drug, so this is the cardiac data, okay, and I think this is really, yes, it's a diabetic drug and it's an hypoglycemic drug, but look at this. So it takes time. It takes 3 years, but primary outcome, that was all cardiovascular events. But if you look at death from cardiovascular disease, there's a hazard ratio of 0.6. So out there toward the end, that's a 38% reduction in cardiovascular death. Here is death from all cause, 0.680, 32% reduction. And a hospitalization for heart failure, a ratio of 0.65. That's a 35% reduction. So this is real. It looks real. The drugs have side effects. Urinary infection, mycotic, women more than men, a lot of GU infections, a lot of mycotic infection. The second drug that came out was in canagliflozin, and has now been a black box warning's gone on that drug for doubling the lower extremity amputation rate. Okay. There's renal insufficiency. There were flares of acute renal failure. It is a diuretic, so it's always complicated when they're already on, their heart failure patients already on diuretics. So you're adding a diuretic, you have to know that you can anticipate a diuretic effect. So you counter that with lowering your diuretics, and it's a hypoglycemic. The effects that I think the A1C drops were modest, 0.4, 0.5. So it's not a potent hypoglycemic drug. But I think this class of drugs is probably here to stay. And if you can start doing that by causing glucose to spill in the urine, and you're getting this kind of outcome, there's obviously some explanation in there what's happening at cardiovascular endpoints, because it's something. And their blood pressures went down. I think they went down 4 or 5 millimeter blood pressure drops. So the purists say, oh, that's just an antihypertensive drug. You've just improved cardiovascular outcomes because you lowered your blood pressure. It's just an anti-diabetic drug. You improved cardiac output, but now the reason all these trials are being done is because 10 years ago the FDA said, look, no new diabetic drugs without looking at cardiovascular outcomes. That's not, it ain't happening anymore. Okay, and then sure enough, you get this kind of data. Okay. I don't know the answer. Is it atherosclerotic mechanism? Is it some sort of endothelial vascular mechanism? It's happening somewhere in the vasculature. And then just now that there's another trial that's come along with this one, but then they started looking at renal endpoints. Okay, if you go out far enough, you start to what they called incident, which was appearance of proteinuria, or worsening nephropathy, which was declining GFR. So the differences are small, but they're real, they're measurable. The hazard ratio was 0.61, but you're talking about a very small number of patients. Interestingly, this is a reminder of the natural history of diabetic nephropathy. So go back to this. How do you make it go back?
The back arrow, or the left arrow of the keyboard.
So if death is occurring, which one's all death? Death from any cause. So you're in the 10% range, right? And here,
Hold it, Laura.
and here you're seeing some appearance of nephropathy at a 10% rate. So it's almost like death and renal failure are kind of coming at the same. And these aren't dialysis patients. We're just talking about the appearance of nephropathy. This at the bottom was all events. So very few of those were doubling a creatinine, and a tiny, less than 1% were evolution to dialysis. So most of that renal data was evolution of proteinuria, and that's even before there's renal insufficiency. So yes, they qualify as our definition of CKD, but the point is they're dying as fast as they're entering a renal endpoint. And that's pretty much recognized in the Getting Waters.
I can get some. Thank you.
That probably in my clinic, the diabetics who come with CKD, proteinuria, and renal insufficiency, they're probably more likely to die than enter dialysis over time. So it's a recognition, and that number isn't really known. I generally say half, but it's probably more than that. So it's kind of dependent on the doc, but I spend more time now in the front end of my evaluations with patients is kind of, rather than focus on their diabetes and CKD, it's more kind of this. It's more of the risk factors, and it's your blood pressure control, and are your lipids controlled, and are these inhibitors and beta blockers pushed in mind. component of LV dysfunction. So I mean, it's how we doing on time?
It's about 10-12.
Are you out of here at 10 sharp, or are we?
Some of us will probably have to be, but
Okay.
some will stay.
We just want time for the case study.
Okay, so here's liraglutide. This is the other new kid on the block. These are GLP-1 agonists. So these are insulin secreted GOGs. They don't act like sulfonylureas. This is a gut peptide. It's an incretin. It's now, these drugs have been out. This is the leader trial. It's 2 years old. The separations aren't as great, but you can see death from cardiovascular cause, top right, 0.78. And this is a 22% reduction in death cardiovascular events. Non-fatal MI, non-stroke, death of any cause, 0.8 by 15%, hospitalization for heart failure, 0.87. That wasn't statistically significant, but these are more potent diabetic drugs, 0.8, lowering of A1C about, and these are 4 and 5 year trials. These drugs are well tolerated. It has a black box warning about medullary carcinoma of the thyroid, and that's mostly in the lab animals. So very rare human disease, but it's encouraging times when now we have evolving diabetic drugs that seem to have some sort of cardiac protection. And so if you start taking what is standard treatment that you guys do every day, and we start adding in effective drugs that are not only anti-diabetic, but perhaps altering, the cardiovascular profiles and outcomes in our patients, it's I won't say exciting, I'll just say it's encouraging. John?
Disguising myself.
Have you used any of these drugs, John?
You know, I was at the AHA and ACC, and it struck me how, as cardiologists now, we will have to be prescribing. I'm wondering who's going to prescribe these drugs. That's, I guess, what the issue is. Is it going to be the person that controls their diabetes? Is it going to be that the cardiologist recommends that they switch to this? And then if they do switch, how do you monitor it, or who follows it up? I mean, the evidence, I think, is very good evidence, and and then the other issue is, I thought, well, they'll be on yet another medication, but they're on medication for the diabetes anyways. And I think your point is, if we can put them on a medication that it's going to give them the biggest bang for the buck, then.
I was at they had an ASN meeting, this is the American Society of Nephrology, it's the academic group for America, and that drug is a daily injection. They're all peptides, and they're all injection drugs. And there's longer acting drugs now, they're weekly. Dulaglutide is the Trulicity. But there was real data, and they were looking at, these were all entrants with CKD, with diabetic kidney disease, and you can start seeing separations in progression of renal disease. So now you have these, and it's, did I put that in here? No. But when you start, if you start moving upstream in them and you start tackling, diabetes and the cardiovascular risk earlier in the course, because all these trials, most of them were either had events or had multiple risk factors for cardiovascular events. They're 10 plus years of downstream with diabetes. Right? Mm-hmm. So who knows if you start moving these drugs into the...
And that's, when you're going to do a study, you want to do a study where you're going to get lots of endpoints, correct?
To measure.
I mean, so to do the study where somebody doesn't have overt coronary artery disease is going to take a longer time to get a result, but it makes sense, doesn't it? I mean,
they went back and looked. So when you start doing secondary analysis, you're always teasing out things that may not exist. But they looked in that SGLT2 data, and if you took the ones with the early renal insufficiency, those are the ones where you'd get the separations, as far as the measurable endpoints for the benefits. So it's going to happen, and the question is going to be who managed it, what's the cost. That Trulicity is $600 a month, for 4 injections. It's going to eat.
I mean, actually, all these therapies are the most expensive secondary prevention therapy we have now is Repatha, or the other one.
Right.
Yeah, Priolent.
But
But
it,
actually, Priolent presented, and they actually talked about reducing the price, and that makes economic sense, because if you reduce the price, it'll be more available to more people, and they will make more money doing it. So,
Somebody made a comment at your guys' conference the other day that NOACs are the first ones reaching, generic status here in a year or something like that. It's hard to believe, but it is. And that's going to happen to this in 7 years.
Amy and I went to the same talk at ACC, and one of the points they made was there's 30,000 cardiologists in America. There's 7,000 endocrinologists.
Yeah.
I texted some of my primary care people down like in Rushville. They don't know how to use SGLT2 inhibitors.
Right.
Everyone's on
and
metformin.
Yeah, and glipizide.
Yeah. metformin.
Well, and it's the same with no family doctor is going to usually will take the time
Right.
to see whether or not, Repatha will be covered. They say, well, just go see your cardiologist.
And they're on multiple diabetic drugs, and now, the beauty of these injectable peptides, the hypoglycemia rates are very low. Okay? Now, there was some with the SGLT2s, so it's all of that. It's how do you incorporate it into an already complicated diabetic regimen,
Right.
and who's going to deal with the hypoglycemia? You started this patient on this new drug,
Right,
and
right.
it happens in the first 6 weeks of drug, and the primary care doc doesn't even know you're on it, right? Other than the note you sent.
Yeah, because they didn't read it.
Right.
Okay, quick case. This
Because
lady
they-
I saw a year ago. So she'd been in the emergency room, 55-year-old African American. She presented with shortness of breath and a blood pressure reaching 243 over 121. And somehow in the ER, the decision was to stop her ACE inhibitor. So she came to my clinic. She had long-standing diabetes, hypertension, and anemia. She had recognized retinopathy. Her meds are on the right, so she comes in on 3 vasoactive drugs plus nitrates, not really an antihypertensive, but it's kind of a heart failure regimen. And I think those were just started in the ER. So she's basically on clozapine, carvedilol at maximum dose, insulin, Aleve, gabapentin. So the interesting thing in her story was I dug through her chart and found that just 14 months prior, which was January of 17, her creatinine's at 1.5. And in the past, her urinalysis, she had proteinuria. So the issue is, what does she have? Well, 15 months ago, she had CKD. She had a GFR that was probably no better than 60 ml, and she had detectable proteinuria. And that was established 15 months ago. So her exam, she has retinopathy, she has clearly uncontrolled hypertension. She has a few rows, she's in some degree of left heart failure, and very little edema. And her x-ray hinted at mild. Interstitial edema is ever mild, but it was mild by that. Her echo showed a normal LV, but a thickened LV. So she has LVH, and she had, interestingly, a very small effusion. And now her creatinine's 3. She has anemia, or hemoglobin's 10.8, but she's had some of that in the past, so I looked back, so that was really no change. So that's kind of the indolent chronic. And amazingly, even when your GFRs get to this level, most people aren't severely anemic, and most of them aren't on EPO. So she had an A1C of 7, and we do a spot urine albumin to creatinine, so you assume there's 1,000 milligrams of creatinine in the urine, so you can just take that ratio and multiply it up to 1,000 on the denominator, and she would come out with 2,237 milligrams of albumin per gram creatinine. So it's nearing nephrotic, that's heavy proteinuria. We saw her drugs, and that was her lipid panel. I stuck back in there for you. So interestingly, she was on no lipid drug. She had no cardiovascular history. None of this echo was new from the ER. So all this was sort of new. So what did she have? Well, she had uncontrolled hypertension. She now had fluid retention but mostly it sounds like it's more left heart failure, right, with preserved ejection fraction and LVH. But her creatinine has doubled in a short 15 months. We'll kind of get to that in the question. So what is that? Well, what stage would that be? A creatinine of 3 would put her GFR around 20. Okay, so that's stage 4. What degree of proteinuria? Mild, moderate, severe? That's severe. She has gram quantities of protein. Her long early days of microalbuminuria and all that, that horse is gone. What blood pressure target, and what about the ACE inhibitor? Does the fact that she showed up in the ER in hypertensive overload on an ACE inhibitor require or necessitate the discontinuation of the ACE inhibitor? I don't think so. I mean, what would cause discontinuation of the drug? Refractory hyperkalemia, that's the most common cause. Or sudden, acute, unexplained changes in GFR. Right? Now, theoretically, could some of that creatinine drop have been ACE inhibitor related? I doubt it, but it could have been. If she'd been on diuretics. Was she currently on sodium restricted diuretics? No. Are those combinations safe? I think absolutely yes in renal patients. So when do diuretics and ACE inhibitors catch up to the kidney function? Over diuresis. I mean, if you diurese a volume overloaded renal failure, heart failure patient to the point of intravascular volume depletion, sure, their GFR drops. If you over-reduce their blood pressure, and if the kidney function is pure hemodynamics driven by blood flow and blood pressure, and if you drop their blood pressure in a short time to 90 over 60 and 100 over 50, then sure, you see GFR changes, especially if they have kind of established hypertension, like this lady is going to have kind of small vessel ring vascular disease probably. And if you acutely drop her blood pressure, you will see GFR changes. Okay? But does that say that it requires discontinuation of ACE inhibitor? I say not. She's not on a diuretic, which she absolutely needs to be on. A loop diuretic. If GFR is below 25 and 30, the thiazides sort of lose the potency. So I would always put heavy proteinuria, bad hypertension, advancing renal failure, loop diuretics.
What dose would you start at in this?
40 to 80. If they're in heart failure, I'd give it twice a day. Maybe Devin actually give once a day, but I always give Lasix twice a day in anybody that has symptomatic fluid retention.
There's also the issue where you get people that have the so-called cardiorenal syndrome, the creatinine goes up, and then they get better with but they're usually in terrible right-sided heart failure.
Now, I think that's real. Do you believe that's real, that you can diurese somebody out of that
I don't think you ever
right
make.
heart pressure, high abdominal ascites and abdominal pressures? And
Well, I've seen it. Yeah, I mean, we do it, but it's the patient is. They're at the end of the of their failure. I think you're right. I think it can become, but there is a point where I had a guy who had ascites. This is completely different, but
cardiac ascites.
he had cardiac ascites, cirrhosis of the liver. He was getting tapped up to 2 to 3 times per week. He had LV dysfunction, RV dysfunction, terrible neck veins up to here. Sent him to Barnes, and somehow they found out he had renal artery stenosis. He had one surviving kidney. They opened up his renal artery and his ascites all in the way. He was getting liters taken off every week. It was I've never seen anything like it. I wouldn't, But
What was his blood pressure? Was he acting like a kind of an end-stage heart, or did he have
he
high
was
blood
more
pressure?
like an end-stage heart disease. He really was. So I didn't even.
So you think he diuresed? I mean, he had a.
Well, they kept taking. I think eventually they got him, to a point hemodynamically where, his RV function improved, his RV pressures decreased, and
I think that's.
you have to have a pressure differential between your arterial
to drive
filter.
glomerular filtration.
Right.
Correct. So when you have some of these people that have
Such a
very, very high pulmonary pressures or pulmonary or have high venous pressures.
And their systolic pressure 90.
right.
That's right. So
Advanced
so
heart
you're
failure management.
and they're and then some of these people's right-sided pressures are 30.
I think that's real. I mean, I didn't imagine that 10 years ago.
No.
but I
I agree. Yeah.
So
But
Real quick, I want to ask, because this always makes me nervous, when you're talking about when you start diuresing and you start failure patients and their creatinine goes up, but if you push through it, then it comes back down. What's your rule of thumb? Because I had a guy go from 1.8 to 2.4. That makes me nervous.
Yeah.
What I do is I don't do both. So I wouldn't give them new ACE inhibitor and diuretic the same
Right.
day, or the same illness, the same initial management. So if the guy's short of breath, I would diurese him first. And then add the ACE inhibitor once you've reached some sort of plateau volume state. Because now you're going to lower their blood pressure, and you're going to have the intrarenal effects of the ACE inhibitor, which usually they bat off. It's amazing how few people, unless they have fixed renal artery stenosis, severe renal artery stenosis, usually bilateral. A lot of these people are running around with one kidney that doesn't work, right? So it's like that. And if they have any renal disease in their other kidney, those are the people that are the most sensitive to the ACE inhibitors, just from a renal vascular standpoint.
So are we routinely checking a renal ultrasound on our heart failure patients?
You know, I think when you get to the point where, I think you do an ultrasound on these people to make sure they don't have some form of, obstruction.
Disease,
because you see that
disease.
Yeah.
people with, prostatic hypertrophy that,
But I get
So,
that
yeah.
all the time. I get a 12 and an 8 centimeter kidney.
Yeah.
Somebody who has bad hypertension. Well, that's the clue. This
Right.
kidney's drying out.
Yeah.
It's
Yeah.
gone or near gone. So you have probably severe renal artery disease there. And the question is, what do you have here? And the studies, studies just aren't that good to tell you. I don't trust the Dopplers enough.
Yeah.
If you're going to answer the question, you have to answer it with some sort of.
and it depends where you get the Doppler too. If you
Yeah.
you got to have a great lab.
I think if you want to answer the question, I think you
Patient
have
can't
to
be
take them
300
to
pounds.
some sort of antigraph, either direct renal arteriography or at least some
And then their
CT.
creatinine's up to people
Yeah.
die.
But that, I can tolerate that. If your clinical suspicion's real, so by the time I sent it to John with the question, does this guy have severe bilateral artery stenosis? My suspicion's high at that point.
Question about this one. So you said you would start with the diuretic, but at what point are you still comfortable then adding an ACE or an ARB in terms of the creatinine?
Grabbing 3 is fine.
Creatinine,
No.
right? Okay.
Now, obviously, you have to watch him a little closer. In the initial period, you're going to see, but she was on it. I think that the scare came in the ER when they saw her with all this, and they said, "Oh my God!" Somehow they fixated on the ACE inhibitor effect as being detrimental. It was probably good for her up until that point, but she just developed severe uncontrolled hypertension.
And separate from her, where it appeared that she had some sort of acute decompensation of some sort, and just the chronic patient that seems and blood pressure's reasonably well controlled. At what point do you consider withdrawing an ACE or an ARB if they're not hyperkalemic? Do you at all?
6. I had this happen to a guy just recently,
Because again,
type 1
nervous.
diabetic, going to transplant. I had his son, we had him all tapped, on tap for an elective kidney transplant. His creatinine was 6. And you know what that taught me? He was never clinically hyperkalemic. I think he bumped his potassium once. So I stopped his ACE inhibitor and vasodilators. He'd been on for 15 years. And what do you think happened to him in the 6 months between that and getting his kidney transplant? He went into AFib. So is that chance? I guess. But, what do you think? Do you think ACE inhibitors and keep people out of AFib?
I don't know, but it's a good question. But if you remember the first studies that were done with captopril, they accepted creatinines. Or if your creatinine went up and it went up to 2.5, it didn't mean that you got kicked out of the study. It was continued. So that's in patients with heart failure. So it means you have to be very careful, I think, but we do it.
The amazing thing is people can take ACE inhibitors at very low GFRs if they're on stable potassium.
I think it's less dangerous than aldactone. Spironolactone, I think.
I agree.
I get really.
The combination especially.
And then,
You
then
have-
if you have them,
You have to sort of preempt. The question is what creatinine do you cut ACE inhibitor spironolactone patients down?
Yeah,
And I think any creatinine over 2.5, you're just
and that's what
you're risking it.
Yeah.
With
With
the
the
spironolactone.
hyperkalemic.
Yeah.
You give them a thorough diet instruction, and you can get a lot of people's potassiums easily controlled if they truly understand what is dietary potassium. Medicare will pay for a dietary consultation, one in CKD. What's left here? So what's her diagnosis? Oh, we forgot the NSAIDs. Let's just go back. What do NSAIDs do to the kidney? I mean, what's the predictable 3 effects you can bet every time? It lowers the GFR by blocking prostaglandin vasodilatation, so that lowers renal perfusion. That's creatinine bump. It blocks renin, which downstream will block aldo. That raises potassium. And prostaglandins are natriuretics. So endogenous natriuretics. You block prostaglandins, you block natriuresis, you fluid retain. So you can make a creatinine bump, a potassium bump, and the edema worse, just giving NSAIDs to a heart failure.
Is there an NSAID that's worse than the other?
I don't think there's one better. You only want to tell
So
you.
like ibuprofen is just as bad as, okay.
Celebrex, is that okay to cause tubes? No.
Same story. All the renal effects are essentially the same. And so many of them are available over the counter that people take them and you don't even know it. The best one is Equate. They go to Walmart, they buy Equate, and I've even gone to Walmart to look at Equate. You can get Equate that's aspirin, Equate that's Tylenol, and Equate that's ibuprofen. So the patient doesn't even know what they're on. They say, I just take Equate, and you don't know.
Right, that's just the generic brand name.
Yep,
Yeah.
but you
Yeah,
can
yeah.
literally Equate is 3 different drugs, one of which is an NSAID. So what is diabetic nephropathy? Hypertensive proteinuria, CKD. Could she have renal vascular disease? Sure. Do I go looking? No, unless you have some compelling, anatomical explanation, or you had, sudden, severe, So is she pulmonary edema? Pre-pulmonary edema, sort of. Is it in the differential? Yes. I wouldn't go looking for it. Will she progress? She sure will. Is she a candidate? She's young. She's 55. She's had no cardiovascular morbidity at this point other than LVH. So she's a great candidate. If she passes screening, they would all get screened with some sort of stress type of study in cardiac cath if there was any concern. Why isn't she on a statin? Is there data that you should give every diabetic in this country a statin? Regardless of their lipids? Yes. There's mortality data.
And actually the endocrinologists have a goal now, and their goal is an LDL cholesterol less than 55.
Is that right?
I believe it is, yes. It's
So that-
actually is
Oh, wow.
aggressive.
It's
But
more
that-
aggressive than for
Coronary.
first,
But
second.
that trial, that low dose of atorvastatin trial that was just, randomized diabetics, just yes or no, it had nothing to do with the ambient lipids. They didn't measure the lipid or they didn't target the lipid. They just said statin, no statin, and there was mortality benefit, just low dose statin. So, you don't even have to look at her lipids. Sure, her LDL was 100, but I wouldn't hesitate to give her high dose statin. And then our big questions are, what's the future for SGLT2 and GLP-1 agonists? I think we're getting there. And which one first? I could see if they're a hypertensive, fluid-retaining CKD patient, if these drugs get approved in CKD, then the natriuretic effect of these drugs is desirable.
At what point do you stop metformin or recommend?
Yeah, they've eased it now. It's GFR at 30. So if they're stable, and they say don't start it at below 45, but you can treat them out to GFRs of 30, which is a creatinine approaching 2. So I leave them on it. I occasionally, if they're on 2,000, I'll write back. You get nervous, but the drug's so good and it's effective. And I haven't seen a stable outpatient on metformin develop lactic acidosis ever, even with creatinine 2. So I don't know where the safety line is. The FDA says GFR 30.
On the SGLT2s, you said you might see a little change in GFR or creatinine with that. What would you say would be kind of acceptable?
I think it was a point. It was so in a creatinine change. These were measured studies. Their GFRs went down by maybe 5 or 6. That would be a creatinine change of 0.1 or 0.2. Yes, and over time it returns. It's probably that when they talk about TG feedback. I didn't put all that in the target system. They hint that there's this transient effect that alters the way the glomerulus is early in diabetic kidney, there's hyperfiltration. The kidney actually hyperfilters in early uncontrolled diabetes, and some of that is thought to be blocked out by these drugs. So I think it's wishful to think these drugs have all these effects. But the bottom line is those cardiovascular curves, those are real.
I've seen a similar thing with Entresto, where the GFR goes down a little bit, and then months into
It's
the
ARB.
yeah. Months into the treatment, it gets better.
Yep.
Are you seeing any negative effects with Entresto as far as renal goes?
Well, I've personally treated one, but I've talked with your guys' heart failure coordinator about it, and I've seen the creatinine go down with the drug. So I mean, I think it's real, and it has to be some sort of beneficial hemodynamic.
So their heart failure is better, their cardiac output is better.
Yeah.
Maybe it's right heart failure, like John was talking about. So maybe it's all this. What do they do with these decompensated heart failure patients when they start having the right heart failure, and suddenly you make that better as well? So now you may see GFR changes because you're just altering the pressure gradient across the kidney. That I think that's real. So they're asking about Entresto. I prescribed it once in what I do is my patients already have renal failure. So when that comes up, they're already creatinine's over 2. So
Right.
what I give them the ARB. And I try to match out the half of the Entresto that I think is going to give them the biggest renal effects, right? And if they can stably tolerate ARB, then I say, well, then you go on the Entresto. Now, it's still going to have some vasodilatory effect, right? But is your experience that creatinines don't worsen and in fact improve on Entresto?
I mean, it's a little bit like that argument I made with the diuretics, and I mean, if you can improve cardiac output, sometimes you can improve your renal insufficiency.
Lower right heart pressure.
Yeah, so you can. Again, you just have to be careful.
When I've had to reduce their diuretics too after they've been on Entresto for a
Yeah,
little
I
while.
always reduce the diuretics when I start.
It's
Why do you do that?
they just don't need it.
Because you have a natural diuretic effect with Entresto anyway.
Yeah.
Right.
And so you're worried about bottoming out right when you start, so you kind of lower the diuretic, and then if they get fluid overloaded, you just bump it back up.
Yeah.
I've had
I mean,
patients.
I haven't done
You don't
that.
have to drop it.
Oh, you don't?
I haven't,
Drop the
but
volume overloaded.
no, that may be
Yeah.
no, I may be good.
I
must admit,
don't discontinue it or drop it initially,
You cut
but
it in
if they
half.
need to later on,
Are
He
they
told me to always cut
symptomatically
it.
improved on the drug?
yeah.
It's actually, I don't know whether it's a placebo effect or not, but I've had a couple of patients that come back even after 2 weeks
Oh,
Yeah.
and feel completely different.
Yeah.
Definitely has
Which is hard to
but
believe.
they don't seem to feel that.
Because
Yeah.
it is,
I would say it's like
you know,
80-20.
it was compared with an Allopril, which is,
Are you converting people off ACE inhibitors if they're stable?
yeah, I am, but especially if the rehab is still,
Below 30?
and the insurance company will pay for it.
Right.
Yeah, you have to get it
Yeah.
approved by the insurance.
That's a lot of patients.
It's getting easier and easier though.
Yeah,
There are a lot of
With
people
all
out there
No,
with
you're
stable ACE inhibitors, and so you're targeting those patients.
Oh yeah. It's recommended for stable heart failure patients. That's when
Unstable regimens of ACE
unstable,
inhibitors.
yeah, with symptoms still.
So what's the creatinine cutoff?
I don't.
I
Well,
think it's about
is it?
2.5.
Yeah.
For most of our drugs, we do about 2.5.
Have you done that where you titrate them up on ARB first?
Yeah.
Just
Yeah.
to see?
I always start them on
Yeah.
or ACE
So I'll start and then do it to
So that seems to make sense. I talked to your boss about that once. He thought that was reasonable.
Yeah.
But because you just never know with the TSM. If they have, some people have creatinine 2.5 or their GFR is pretty low, and 20 now. And some people are just going to get hyperkalemic on ARBs and ACE.
So when do we
Diabetics.
send people to you?
That's what that was my
When?
question too.
Yeah,
When do you
when
want
we
to
have
see
all
that?
these
to
people.
start those new diabetics.
Yeah, that's right. So you can manage their hypoglycemia.
Yeah.
The scary thing, that Accord trial, you read that Accord trial that came out, 5 or 6 years ago, the ACP, last month, in their general recommendation, this is a large group of recommendations as far as glycemic control, now have raised the bar for raising A1Cs back up to 7, above 7.
Right.
They say there is cardiovascular risk to lowering A1C below 7, and they've come out with the term of de-escalation of diabetic management, right? So those patients were mostly 10-year out diabetics with either the risk profile or the established events, right? But that Accord trial, there was a 22% worse mortality
Right.
to get your A1C to 6.4.
And they thought it was due to
I was
hypoglycemia.
gonna say, is it all the hypoglycemia with the?
Well, but whatever that, whatever it is that it does, I don't know.
I think that's too simple.
So do I, yeah.
So
Yeah.
when they start doing the secondary analysis, which is, trying to separate the weeds, and which is, I don't think you ever know what you're seeing. But it was the ones that had the biggest drops. So when they took the patients entering the trial with A1Cs over 8, and they got to 6.4, those were the ones that had the enhanced death.
And it's interesting because if you measured our, hemoglobin A1C, it's
Five,
often
yeah.
5, all that sort of thing. So you'd think, it's one of those things, again, where it's important to do studies. You think lower is better.
Or are those
But here's a
patients
case
just
where
sicker?
lower
They're
actually
sicker
is
to begin
worse.
with.
That's their point.
They've
They're
been
saying
living-
if they're
they've
10
been
years
living
out and
with
they
A1C
have the
10.
burden, if you're 10-year
Unknown.
diabetic and you have the burden and your life expectancy is, some limited number, they're saying don't go below 7. It's crazy. And I think they're right. There's something to it. So the question is where's the cutoff? The 58-year-old guy who doesn't have any heart disease, and he's, so he start loading up and getting their A1Cs. The endpoint measurement that's, I think, clear in type 2 diabetes is microvascular disease. You delay or prevent renal, proteinuria, and retinopathy. Those endpoints are measurable and proven. Okay? They're modest. Okay, and maybe you can measure an MI rate, but some nihilist said, well, you can do that with an aspirin. Right? You can give a diabetic 81 milligrams of aspirin, and you're going to just about match the whole effect of getting their A1Cs below 7, right? In the measurement of coronary events. I think that's true, John.
I don't know.
So, but if you're adding risk and taking people as A1C to 6.4 in the Accord trial, then you need to stop. And the problem is that the endocrinologists, they think lower is better. Legacy, that term legacy effect. So if you front load these diabetics with low A1Cs, you get this persistent legacy. And it's probably real. Okay? But the question always is how low for how long with what cost, right? Can you keep them from being hypoglycemic? Can you keep them from having exaggerated cardiovascular event rates and death? In the process of trying to prolong their life, you're shortening their life. Those are tough questions, but I think these drugs they're gonna become standard drugs.
So when do we send our patients to you?
I was just gonna say, what was that?
What question are you asking?
So I have a guy in clinic that creatinine's 2, but it's been 1.8 to 2 for years that I've seen him. He doesn't have a nephrologist.
Sure, we like to see them, but what am I going to do? I'm just going to tailor their blood pressure meds and tailor their blood pressure. I'll give them a diet, a renal diet. I still use dietary protein restriction in some of my patients because it's mostly in the advancing, so they're already progressing to end-stage renal disease. It lowers some of that uremic feeling, the blahs, the uremic burden, and in the old trials, it slowed progression. So I think you can get people through advanced renal failure longer on low protein diets. The nihilists in my training days would always say, yeah, but they couldn't sit in a chair because they were just sitting on their butt bone, right? Because they lose so much meat that they were uncomfortable sitting because it hurt to sit on your rear end when you had no meat on it. But the bottom line is that acidosis, hyperkalemia, the anemia, the bone disease. When do you treat PTH and CKD? 3 to 4. I wait till it's 3 times normal. So normal PTH is around 75. So I let him get to 300. I had a patient the other day who self-referred to a Tampa, Florida ear, nose, and throat endocrine surgeon because his PTH was 300. Okay, and I measured it. I discussed it with him, and I told him that's treated with low-dose vitamin D. He went to Florida and got a subtotal parathyroidectomy. 3 out of 4 glands removed, and he came back, and guess what he had? secondary hyperparathyroidism. Because it's a polyglandic, I mean, it affects all the parathyroid glands. So, yeah, I guess if they have a complicated PTH question, send them to me.
But he probably thought that surgeon in Tampa was great.
He said the surgeon told him he would do it for his father.
Yeah.
Who's dead?
I think every time.
Acidosis. When do you start bicarb? There's a
I
trial.
was gonna ask about that.
There's
too.
there's a national trial now on does bicarb even delay progression? So is there something about taking the burden off the tubule of because when you think about it, when the kidney loses 3/4 of its nephrons, your GFR is 25, your creatinine's 3. The amazing thing is those remaining 1/4 nephrons are always in this adaptive process of trying to make up for the declining function, right? So that means those 1/4 tubules now have to secrete 4 times the hydrogen ion that the organ used to secrete, right? And the amazing thing is the acidosis manifests late. You don't see bicarbs drop below 20 till their GFRs are below 25. So what's happened in that interval? Well, they've lost 3/4 of their organ, and that remaining quarter is now functioning from a tubular standpoint of secreting all that acid. And some people want to believe that maybe that's injurious. That's part of the damage. Is the kidney is the work hypothesis. That as the kidney fails, it accelerates failure by trying to make up for the failing neighbor nephron. And so this trial's in. So when do you treat it? I treat every bicarb under 20. This trial's pushing everybody to 22. There's some epidemiologic data that says bicarbs over 28 are increased heart failure risk. So you don't want to treat them out of the normal range. But I would get everybody's bicarb. If you're going to put them on bicarb, get all their bicarbs above 22. Sodium bicarb is just, it's an alkaline. It's just neutralizing acid. You're taking the burden of the 60 or 80 milliequivalents a day that we make, that the kidney excretes, then you're just taking part of that burden away. You're just neutralizing it. It doesn't cause edema like sodium chloride tablets will, but it's a sodium salt. Some patients on sodium bicarbs will. You'll see some fluid retention from it, but it doesn't have the same volume retaining effect of sodium chloride. Something that bicarbonate ion is not chloride ion, and you don't get the volume